pneumothorax. So talk about pneumothorax. We're talking about accumulation of air in the pleural space, which can cause now either partial collapse of the lungs or complete collapse of the lungs. So pneumothorax, that is air in the pleural space. And we know what the pleural space is. That space between the lung and the chest wall is now the pleural space. So we have classification of pneumothorax or the different types. We have spontaneous. Basically, spontaneous has no known cause or occurs as a consequence of the nature of the cause of a disease process, like in cases of COPD or tuberculosis. So, and can be classified further into two, that's primary and secondary. When it's primary, it occurs without an underlying lung disease. But now, when it's secondary, there is an underlying lung disease. So that is spontaneous pneumothorax. Then we have traumatic pneumothorax. Traumatic, that's the word trauma. So that means following any penetrating or non-penetrating chest trauma. And that can cause either with or without bronchial rupture. The traumatic again can be classified into two, the open and the closed. Open, there is communication between the air and the pleural space. That means that now even the air from outside is able to get in and get the pleural space. With the closed, the penetrating agent has not allowed any communication between the airway and the pleural space. So it's sealed off. And then we have iatrogenic, which is now as a result of diagnostic or therapeutic medical procedures. Can either be intentional or a complication. But now when one is undergoing through a given procedure and they ends up being penetration into the pleural space. So in cases like thoracentesis, in cases of doing like lung biopsy, mechanical ventilation, and you mistakenly rupture the pleural space. Then we also have the tension pneumothorax, where now air enters the pleural cavity and cannot escape. So it has been trapped there. And that's going to cause now increased intrathoracic pressure because now of the large amounts of air that has progressively accumulated within the pleural space. The clinical features, that sudden onset of unilateral pleuritic chest pain. There is a breathlessness. There is cyanosis, rapid pulse, signs of peripheral circulatory failure. On inspection and palpation, there's dyspnea, there is a use of accessory muscles of respiration, shift of the trachea, fullness of the chest on the affected side, diminished chest movements are some of those clinical manifestations. On percussion, you'll hear hyperresonance on the affected area where there is pneumothorax. Then your investigations, chest X-ray, show you that collapsed lung and the pleural air, or we show you that is pleural fluid that is present. That's a collapsed lung. The mediastinal shift has moved towards the right, as what you see during your chest X-ray. The other things you can do for diagnosis, you can do the chest CT scan, the ultrasound, still the same. The arterial blood gas levels, which help you to check on that more, especially if in severe cases. Treatment, to manage that, more especially like in the primary pneumothorax, you just need to manage with oxygen therapy, and it's able to resolve normally, even without any further intervention. But if the patient is having severe symptoms, we can what we call the percutaneous needle aspiration to remove out the excess fluid or air that is trapped. If it fails, then we can do chest tube insertion. That's intercostal tube drainage to allow us again to drain, and it's attached to the underwater seal drainage. I don't know if I'll be able to have that to show you the underwater seal drainage, but I want to allow you now to remove the excess air and fluid that has accumulated in the pleural space. Tension pneumothorax, we talked about it, air getting into the pleural space but cannot be able to escape. That is needle aspiration. So you just use that to remove the air that is trapped or the fluid that is trapped. Secondary, again, intercostal tube drainage. Tension pneumothorax is a medical emergency, and you can do just needle aspiration, which is inserted to the pleural space, and then it's left in place until now you just attach the thoracostomy tube, which will allow you now to remove or to drain out the air or the excess fluid that is in the pleural space. Still, that is a procedure that is going on, that is now doing a small incision, making use of the forceps, and then into the pleural cavity. So you can see once you've done that, you can see now that's a catheter that has been inserted just to help now drain this continuously. So you can see here the underwater seal drainage of the chest. So from the chest here, you have a bottle there. It has saline water, and you monitor now as the patient breathes, then the fluid level fluctuates or it keeps on changing, and that helps you to just monitor um, the circulation, and at the same time get to monitor whether there is bleeding. So go and read on sorry, I've lost my slide. So one read on how to just take care of the underwater seal drainage of a patient. You'll be able to see that. You are nursing care. Of course, you observe that underwater seal drainage so that there are no bubbles that are being released. So monitor the chest tube function. Make sure that you just ensure that it's properly connected. Make sure that you are maintaining. Yes, this. Let me go back to this. Yeah, make sure that you are maintaining the drainage bottle below the chest level. So you can see here, it's just below the chest level. Observe for bubbling and tidling. If there is any bubbles, observe for that. Check for kinks or clots or air leaks. There should be no kinks or air leaks. Very, very important. And then do not the chest tube. Just allow free flow of the fluid. Then now, beyond that, in terms of managing the chest tube, if the patient has a chest tube, the general care of a patient with pneumothorax is just to make sure you promote activities that early ambulation. Have you encountered the incentive spirometry or the use of the spirometer? Well, I think I'm going to show you one. Hopefully we have it in the skills lab. I'll show you and how to make use of that. Then of course, for pneumothorax again, provide education that is going to prevent recurrence or that's going to further trigger the disease, like the avoiding smoking, avoiding strenuous activities for the patient, as part of your health to your patient.
Yeah, are you able to get me?
We can hear you. Proceed.
Yeah, so you said that bronchoscopy can be used as a medical or a therapeutic intervention. So the only bronchoscopy I knew of was for inspection of the airway. So I would like you to explain how it can be used for therapeutic intervention.
Okay. Yeah. So we know what bronchoscopy is, of course. The bronchoscope, we already said that. So bronchoscopy can be a diagnostic procedure, and again, it can be a therapeutic procedure. That means that it can be used to treat. In this case, now the airway diseases, which we are talking about here. So there are many ways that it can serve as a therapeutic intervention. One is airway obstruction relief. Remember that some of these diseases you're talking about airway obstruction. So with the bronchoscopy, once you visualize and see where there is airway obstruction, then you can utilize that now to open up the airways. For example, whether there was a foreign body that is causing the obstruction, you can do that to remove that. Or there is a mucus plug that has blocked the airway, you can use that to remove that mucus plug just to open up the airways. In cases of narrowing of the airways, like when we saw it for asthma, you can be able to use it now to open up the narrowed airways. You can use it to suction thick secretions. That's a therapeutic intervention. You can use it to what else? Um, to apply drugs, like for example, if you want to deliver things like vasoconstrictors directly to the airways, like the topic of vasoconstrictors, again, it can be used to do that. So that's one of the very many ways that bronchoscopy can be a therapeutic intervention.
I was going through some notes, and I came across things to do with bulectomy as a surgical a surgical management of COPD.
Mm-hmm.
But I don't understand as the nursing responsibilities when it comes to bulectomies. So can you clarify, please?
You are nursing responsibilities now to bulectomy. Is that your question, or?
Yeah.
Of course, the nursing responsibilities will be the same, like what we had mentioned earlier when we talked about the pre, intra, and post-operative nursing responsibilities. So there could be so many nursing responsibilities in that procedure. Preoperatively, just before the procedure, assessing the respiratory status of the patient, obtaining data, that is the vital signs, patient preparation and education, which includes explaining the procedure, teaching the patient to do the deep breathing exercises, having the patient not take any food as part of your preoperative nursing responsibilities, including administration of medications that may be required to be administered before the procedure, and checking out whether the patient has signed the informed consent. Post-procedure airway monitoring, so continuously accessing the airway patency, the respiratory rate, the breath sounds, the SpO2, monitoring the patient for respiratory distress, encouraging the patient to use the incentive spirometry, teaching the patient the deep breathing. If the patient on a chest tube, monitoring and managing that chest tube, managing pain, encouraging ambulation, all those can be your nursing responsibilities. Again, to go back, you talked about blectomy, just for the purpose of the rest. We talk about blectomy, that's a surgical procedure now, where we remove large bullae, basically those air-filled sacs within the lungs because of the destruction of the alveolar walls. Because remember that we talked about now the alveolar walls getting destroyed, and some of them now are left with large sacs of air that has been trapped within them. Those air-filled sacs can actually compress a healthy lung tissue and again further impair ventilation. So sometimes to prevent now further impairment to ventilation, that blectomy can be done now to remove. Blectomy is done now, very severe, emphasize one of those interventions that you have to do all of the case of now doing bulectomy, and most it can be indicated for patients who have now large bullae, large air-filled sacs that are, and they are surrounding healthy lung tissues, or those who have symptomatic, what we call symptomatic patients. That means that they have recurrent infections because of that bullae, or that presence of that bullae is basically affecting their performance as living.